Good evening, everybody. First of all, I must thank Dr. Banshi Sabu for inviting me to this program and allowing me to speak on this forum. Ladies and gentlemen, we know very well that sugar is a tissue toxin and it damages everything in the body over a period of time. There is no tissue or organ in the body which could be considered as benefiting from high sugar. And this damage is, although slow, but it is steady, progressive, accumulative, and irreversible. That's the reason why we should treat these patients to target right from day one to avoid complications. Now, somebody could ask a question as to why we are segregating fasting from PP glycemia. If everything is bad, so why not just treat everything and why talk about PP hyperglycemia separately? Now, my slide will flow like this. First of all, I'll answer this question, why postprandial hyperglycemia is important and how it is different. Secondly, how breakfast is different from other meals. And thirdly, are Indian diabetics any different from the Western diabetics? So taking the first part, what is so special about the PP hyperglycemia? Epidemiological studies have shown that there is a strong association between post-meal glycemia and cardiovascular risk outcomes. It is more closely related to cardiovascular events. There is an association between PP hyperglycemia and oxidative stress, carotid, IMT thickness, endothelial dysfunction. They are all risk factors for CVD, and it's also been related to retinopathy, cognitive dysfunction in elderly people, and certain cancers. We should know very well that PP hyperglycemia is in a different setting, and fasting hyperglycemia is in a different setting. So when you see the whole context, then the situation becomes slightly different, and it is possible there's two types of hyperglycemia will have two different types of complications. And similarly, fasting hyperglycemia has been linked more strongly with microvascular complications of diabetes. And secondly, we also know that it's a fact that for the major portion in 24 hours, the person remains in the PP state. True fasting is very small, a few 4 or 5 hours in the late night, early morning when the patient is truly fasting. Now, what leads to PP hyperglycemia? There may be mechanical factors like accelerated rate of gastric emptying in diabetics. There may be metabolic factors like accelerated release of endogenous glucose, diminished peripheral clearance of glucose, elevated free fatty acid concentrations in diabetic patients, and behind them may be the hormonal factors like loss of early insulin release, which is crucial in minimizing the rise of blood sugar after a meal, abnormal pulsatility of insulin secretion, impaired suppression of glucagon release, and abnormal secretion of and action of incretin hormones. Because of a variety of reasons, there is a possibility in diabetics for a PP hyperglycememia. Now, talking about the most important question in my presentation, why breakfast is different from other meals. Ladies and gentlemen, we have talked about circadian rhythms in the human system. For a very long time, circadian rhythm is something which makes an activity to happen after a certain period of time repeatedly. There is a master clock in the system, in the hypothalamus, which looks after those activities occurring after a certain period of time. And it's very interesting that every activity in the human body is pulsatile. Every activity in the human body is following a certain rhythm. Now, these circadian rhythms can influence the sleep-wake cycles, hormone release, body temperatures, and other important body functions. And an abnormal circadian rhythm or a breakdown in the circadian rhythms has been linked with diseases like diabetes, obesity, depression, bipolar disorders, and seasonal affective disorders. We know very well that the nighttime human body is different from daytime human body. The system works differently during the daytime and during the nighttime. And because of that reason, body temperature, cortisol hormone, blood pressure, they tend to go up during daytime and then they tend to go down during night. Similarly, melatonin levels, growth hormone levels, testosterone and prolactin levels, they tend to go up during the nighttime and tend to go down during the daytime. We are very well aware of the rhythms of cortisol. Cortisol rhythmicity or circadian rhythm is the major regulator of cortisol secretion, the levels being high in the early morning hours, then gradually going down and becoming lowest in the evening hours. Similarly, we are also aware of the circadian rhythms in blood pressure during the night being lower than blood pressure during the daytime. So, should we not talk about the circadian rhythms in sugar? Whether sugar also rises and falls apart from the size of the meal, also on the basis of circadian rhythms. And these are studies which have shown that post-breakfast rise is more prominent if the person is fed the same carbohydrate meal at 3 times of the day. And this is because of circadian rhythm. Now, how the circadian rhythm works and affects blood sugar levels. There are 3 components of this. First is insulin resistance variation. Studies have shown very clearly that insulin sensitivity in patients with type 2 diabetes changed with circadian rhythmicity, decreasing during the night and increasing during the day. And this is the 24-hour euglycemic clamp study where you can see that the glucose infusion rate was highest during the morning hours and it was lowest during the night hours and early morning hours, suggesting that the insulin resistance is highest in the mornings and lowest in the evenings. Definitely, it will have effect on the blood sugar levels also. Now, let us see what is the blood glucose variation, how the blood glucose level changes. And many studies have shown that starting from early diabetes in terms of early, from the time of occurrence of diabetes, and also as far as HbA1c is concerned, we see that the earliest rise is in the early morning post-breakfast period. Now, this analysis shows that when the cohort moves from HbA1c of less than 6.5 to 6.5 to 6.9, that is just diabetic. Now, that is the time when the glucose rise, PP glucose rise is maximal. The maximal differential is seen at that point where the person becomes from non-diabetic to just diabetic. So this is one of the earliest abnormalities to occur. And then this continues. This PP hyperglycemia is seen in early diabetics with every meal. And also, as the time passes, this remains maintained. Now, why this happens? There is something known as the dawn phenomena. The dawn phenomena says that there is a rise of cortisol and growth hormone during the late night, which leads to increase in the insulin resistance and increase of blood sugar. And to that is added the surge of glucose caused by the breakfast, which is compounded by the circadian rhythmicity. And this is now something known as the extended dawn phenomena. The dawn phenomena, which is superadded by the effect of higher glucose rise after breakfast, is the extended dawn phenomena, which we see, and that is why breakfast becomes a more important meal in the day of a diabetic. Now, thirdly, this circadian rhythmicity can also work through causing changes in absorption variation, and this study has shown that the median blood glucose excursion, the delta blood glucose, was higher at breakfast as compared to other meals. And this is a very interesting study. In this study, the same carbohydrate meal was given in 3 meals, breakfast, lunch and dinner, and this is CGMS data. Now, they concentrated on 2 things. Number 1, what was the peak blood sugar which was reached after the meal? That was delta BG max. And what was the time at when this peak was attained? That was the delta T max. Now, you can see here very well that the rise of blood sugar after breakfast was something about 2 times the rise of blood sugar after lunch, and it was also significantly more than the rise after dinner. And it was the same carbohydrate meal during all the three meals. The same carbohydrate load was given. So, because of some reasons which we have not discussed much, the rise of blood sugar is higher after breakfast as compared to other meals. And not only that, it is also faster. The peak blood sugar was reached at 95 minutes after breakfast as compared to 120 minutes at lunch and 125 minutes at dinner. So the rise is heavier more intense, and also quicker after breakfast. That is what it makes breakfast a more important meal during the day. So in addition to carbohydrate intake, the size of carbohydrate, the time of the meal also contributes considerably to blood glucose excursion. And this is Indian data, CGMS data in Indian patients, which has also shown that the early and more intense rise of blood sugar is after breakfast. And not only that after breakfast the blood sugar rises to higher levels and also more quickly. But when this happens, this effect is also continued throughout the day. We can imagine the whole daytime blood sugar as one common string, which is tied to two different walls in opposite ends. You elevate one end of the string and the whole string gets elevated. Now, when this post-breakfast rise is brought down, then you can see that everything is brought down. With the same medication, we did not touch other meals, neither in terms of size of the meal nor in terms of medication which were given. But when you bring down this post-breakfast blood sugar level, then during the day, all blood sugar levels tend to come down. So it's important, therefore, that lowering the post-breakfast glucose spike is the key to achieving effective blood glucose control across the day. And why I'm highlighting this here, because when we are sitting in our clinics as practicing doctors, then we do not view breakfast differently from other meals. Now, answering the third question, are Indian diabetics different? Now, an Indian diabetic patient, the post-breakfast challenge is further complicated by two inherent issues. One is high glycemic load. We are basically carbohydrate eaters. Our diet is mainly constituted by carbohydrates, and also we have got a high glycemic response. That means that when we eat a standard carbohydrate meal, our sugars tend to go higher and quicker as compared to the Western population. So this is a comparison of Indian population with population of other countries and races. And you can see here that the post-meal rise of Indian patients is more intense and higher as compared to other ethnicities. Now, this starch study showed that in India, 64.1% of the total calories came from carbohydrates in diabetic patients, and in non-diabetics it was 66.8% coming from carbohydrates. So basically we are carbohydrate eaters, and the Indian gut handles much more glycemic load as compared to the Caucasian gut. So this is one reason why Indians are different. And not only that, one more interesting fact is when people of different ethnicities are given the same carbohydrate meal, then you can see that these black bars are Indians and these are Caucasians. So the rise in blood sugar is more intense and higher in Indians with the same carbohydrate meals. So not only that we eat more carbohydrate, but when we eat the same carbohydrate, we have higher blood sugar elevations. So this results in higher glycemic peaks and excursions in Asians as compared to Caucasians. And for these reasons, ladies and gentlemen, we can summarize that with the available evidence, it is clear that post-breakfast blood sugar is especially more difficult to manage. There are biological reasons behind this, why there is a tendency of blood sugar to rise more to higher levels after breakfast. There is always an individual variation, but this general rule applies to the society, and this is true more so in Indians. For that reason, logically and ideally, we should be using more of AGIs like voglibos more aggressively at breakfast in Indian type 2 diabetes patients. So this is a concept, using voglibos with breakfast, so which I am trying to present here. And you see the dichotomy of approach in India and in the West, that AGIs as a class is not mentioned in the ADA ESD recommendation because their carbohydrate load is very low, very less as compared to India, and they feel that this is not an effective medicine, leads to side effects, so it is just not mentioned in the ADA ESD guidelines, but in our country it is quite important. Thank you very much for your attention.